Please join me in welcoming to the Distinctive Voices podium, Dr. Patricia Ganz.
Thank you. It's my pleasure to be here and in person deliver the results of a recently completed Institute of Medicine report on delivering high-quality care. But before I actually launch into my own talk, I want to share with you a video that we made specifically to disseminate the messages in this report, and I hope you'll see that the patients and the doctors who speak in this report tell the story probably better than I'll tell it to you. So I'd like to step down from the podium just now and beg your indulgence to watch a video for about the next 20 minutes.
It's very difficult to hear the word cancer. My mother and I were walking down the street and we got a phone call from my oncologist, and she said it was stage 4. It was absolutely devastating. One of the hardest days that I've ever been through. The two of us started crying, and it was raining, and I felt like the whole world was crying right along with us.
That moment when I was first told that I had cancer, I was like, wow. This can't be happening to me. You think about your family and all the things that you dreamed about, and then you become frightened. The doctor was focusing on the tumor, but not on the patient, and I could feel that.
It's like time froze. Everything got really quiet. I didn't know what to do. I didn't know what it meant for me in my life. Is my health insurance good enough to cover this? How much work do I need to miss? Will I keep my job? And so all these unknowns were flowing through my mind and causing a lot of stress and anxiety.
I never imagined I'd get breast cancer. Was it difficult to hear? Absolutely. I never cried, but I was very angry and I was very fearful. It was a couple of months before my daughter's wedding, and I kind of felt I wasn't going to be alive for it. You want your life back. So I just got ready for the fight.
We know that when patients are told they have cancer, it's going to be jarring, it's going to be alarming, it's going to invert their world.
They are so vulnerable because, quite honestly, their life is on the line.
One would expect an entire system to snap into place that would ensure that this patient receives all the treatments that he or she needs. That is not the way that our system works. We have the most highly trained oncologists, but because we don't have coordination among all these clinicians, this care doesn't serve patients well. Sometimes it can even harm patients.
We have a culture that says the more we do and the more complicated it is, it must be better. We have ignored the reality of what is happening around us.
We've had great scientific advances and we can give great targeted therapies, and all of this is extremely costly, and nobody knows this up front.
Patients start making decisions which are terrible trade-offs, like, do I pay for this treatment that the doctor says will work, or do I pay for my grocery bill?
And so that's really where the urgency comes in. One, the cost of cancer care, but two, the number of individuals who are going to need this care.
A major shakeup is necessary.
It's really not a matter of do we need to fix it. The real question is, how can we fix it?
And if we don't get it right, we're going to just break the bank.
We will outstrip the resources for cancer care and frankly bankrupt the healthcare system.
Cancer care in America has reached a critical crossroads. Findings issued in a recent report by the Institute of Medicine paint a clear and disturbing picture. The current system delivers inadequate care at an unsustainable cost. People with cancer, like Maddie, Dikla, Willie, and Amy, must engage with a potentially deadly foe. Yet, like millions of Americans traveling this difficult path, their individual needs and complex health conditions are routinely overlooked. Adding new urgency to these critical challenges is an unprecedented shift in demographics already underway. More than 1.6 million Americans receive a new cancer diagnosis each year, and that number is climbing sharply. One of the strongest risk factors for cancer is age. It strikes, on average, around age 66. The first wave of baby boomers turned 65 in 2011. Around 10,000 more now turn 65 each day. By 2030, the number of new cancer cases in America will balloon to 2.3 million per year, a projected increase of 45%.
It's impossible for us to continue along providing larger and larger amounts of care to more and more patients with cancer without in some way ensuring that we're providing only the treatment that patients need and patients want.
And that does give us an opportunity to really stop this fast-moving train that we've been on, and instead to pause long enough to say, what would a high-quality cancer care delivery system look like?
Inflammatory breast cancer is one of the worst forms of breast cancer. In my case, I have a terminal diagnosis. I went to see this world-renowned oncologist. He said, this is what we're going to do. We're going to do a mastectomy. We're going to do chemotherapy, radiation, and then we're going to go back and do the most intense chemotherapy again. He said, we're going to fight, fight, fight. He said, this is what I do for all my patients. He never asked me what I wanted out of the treatment. It didn't make any sense. I mean, I would have done all of those things, but, I asked him, is it going to give me any benefit down the road? And even he said, it's going to be the same outcome. Why would I do that to myself?
Right now, the paradigm in oncology and in other areas of healthcare too is to attack the disease. And because of that, sometimes the patient is a bystander.
Patient-centered communication is really understanding the individual who's in front of you. What are their needs? What are their preferences? Who is that individual at the core? So it's really melding the science that's coming down the road of looking at the key factors within the tumor, but or even more importantly, looking at that patient in front of you and making that individual at the core. So it's really melding the science that's coming down the road of looking at the key factors within the tumor, but or even more importantly, looking at that patient in front of you and making a treatment decision for that individual.
I am being treated for cancer. I take one pill at night called Femera, which depletes the hormones that I have in my body. And then once a month I go and I have an infusion to keep my bones strong. But I also have palliative care. Since I have a chronic disease, palliative care helps me throughout this disease as it gets worse, as I begin to feel worse. And that is going to happen. And palliative care will be right there with me, helping me feel well.
When I first saw the doctor, the first thing he said to me was, I can operate right away. When do you want to come in? I was just like, whoa, wait a minute. His emphasis was on the surgery, and that's what he seemed like he wanted me to say yes to. That didn't go over so well with me, especially without talking to my wife and family about it. So naturally, I didn't make that decision. I wanted to know more about it. And he gave me a sort of a printed sheet and said, well, here's what it's all about.
You can't develop a treatment plan without involving the patient's perspective. That might mean looking together at a website or having the patient pre-read some information before coming into a visit. But then it means answering all the questions and explaining the things that aren't clear.
That's really quick.
My wife and I went to another hospital, and there at that hospital, it was like the difference of day and night. It was a team of doctors, and the whole team made me feel comfortable. They began to tell me the different treatments and how it would affect my life and the quality of life. You know, I felt that I see where this is going to come out all right. I have a chance to make it now.
Cancer is really a complex disease, and we can't always be up to date on absolutely everything. So our vision for the future is that when we see a patient who comes to us and we know what their diagnosis is, up pops a decision aid tool that gives us the latest evidence and guidance on the best way to treat that person, and then even allows us to demonstrate to the patient with a visual aid what would happen if they take this treatment versus that treatment, so that together you're reviewing the evidence and you both understand what the consequences and benefits are from that treatment.
That's good.
Then a patient could leave an appointment with a treatment plan that would spell out what treatments they have chosen with their clinician.
The fact that the patient is leaving with a simple one-page form, and the fact that there is a plan is incredibly comforting to a patient. But also, what are the things that we can do to support you through this experience, and who is there if you have questions? This is a way to transform patient care.
My mom had breast cancer. She was diagnosed when I was 12, and she passed away 2 years later. What I was expecting was when I hit 40, I'd be very vigilant. But breast cancer beat me by 8 years. I was diagnosed at the age of 32. I was going to attack this full on, just fight it with everything possible that was out there. I imagined when I was diagnosed that there would be sort of an integrative system already set in place to help me get the best care. But instead, there was no one there to coordinate my care. I had to do it myself. I was my own caseworker.
A typical person with cancer is being seen by many different physicians and specialists, most who are not communicating with each other. And so the patient, who is physically and emotionally exhausted, is left as the person who is trying to make this coordination happen.
So the breast cancer had spread to my spine and fractured my spine to the point where the spine had collapsed and was threatening my spinal cord. And the only way to correct this was through a spine fusion surgery, this huge surgery that carried a lot of risk. And I wanted the surgeon to speak with my oncologist to kind of know what cancer drugs I was on and how would that react with maybe going into surgery. And what happened is they played eternal phone tag and they never spoke. So it added even more anxiety to the situation I was in going into surgery.
Having cancer over the age of 60 is a lot different than having cancer in your 20s or 30s or even 40s. It's just more complicated. I'm dealing with high blood pressure, high cholesterol, a history of family heart disease, a hiatal hernia, arthritis. There are drugs that are prescribed for all of those.
It's especially a challenge with older patients to coordinate care. They often will have 4 or 5 different specialists who are caring for different organ functions. And the key here really is to make sure that everyone's on the same page. And that coordination of care is something that's so critical, but it takes time. And it really needs to be built into the healthcare system.
My doctors didn't talk to each other about this additional medication that I was receiving. And as a consequence, I was overdosed with a blood pressure medication that made me stagger the next morning.
If one has a unified medical record, one is able to know precisely what is happening with a patient and what has happened over time. However, most cancer patients are treated in systems that don't have such shared medical records. We need shared medical records across all systems where patients are receiving cancer care.
So I'm going to examine you, and then we'll have a chance.
Most of the agents used in cancer care have never been tested in older people, and yet it's older people who will receive them.
They don't know how to treat us. They don't know how to give us chemo. They don't know how much we can take. They don't know the type we can take. They don't know what our side effects are going to be. They don't know if they're going to kill us by giving it to us, because they can only treat us according to the statistics and the clinical reports and the information they have at hand. That is scary. That is really scary.
It's been a struggle for 9 years now. My cancer care costs probably about $250,000 a year. Insurance does not pay for everything. I'm paying about $10,000 to $15,000 a year in medical expenses, and that's a major hardship for me. This stress and anxiety over paying for life-saving treatments is horrible. I do need assistance from my family, and I've known women in my cancer support group who don't have any assistance from anybody. And one woman, her drug copay per month was $1,000. Could be a life-saving drug, but she can't afford it. So what does she do?
We don't discuss out-of-pocket expenses, and yet absolutely there is a very high percentage of patients and families in this country today who exhaust every dime of their resources just trying to pay for even a copayment of their cancer care. And often the outcome will be that the cost invested was not even helpful. So patients are also spending money on treatments that are not going to alter the course of their disease.
Recently, my insurance company changed my mail order pharmacy provider. And I asked them about my coverage for this cancer drug. So the customer service rep gets on the phone and he goes, "Oh, it's $15,000 for a 3-month supply." I'm like, that's ridiculous. It can't be. He goes, "Well, we don't have you in the system yet for what you're covered for." I was extremely upset and stressed out.
Right now, there's no transparency in the cost of cancer care. The doctor doesn't actually know it. The patient doesn't know it. In fact, until you submit a claim, you don't even know what the insurance company is going to pay. There's nowhere else in our purchasing or our interactions where that happens. You know exactly what it's going to cost. You go to the car dealer and they give you an estimate. We don't have that. In the future, we would like to have the ability for a patient to compare costs of the types of procedures that are being offered to them, and perhaps even across different institutions.
The specialist who was suggesting throwing everything at this cancer, my cancer, never said anything about the price tag. I need to have financial transparency. I don't want to go down a road that's a $500,000 road that doesn't give me any value. I want to go down the least expensive road that gives me the most value. And I think it's a consumer right that I get that information.
The state of cancer care in today's rapidly aging America demands immediate attention. Out of its current failings and massive waste, a new system must emerge.
It would take enormous shifts to get us to change the way that we provide cancer care today. The fact is, we have the stimulus necessary to do that because it's a crisis. And out of a crisis, we can achieve the change that we need.
There is no way we can keep going in this direction. There's no way we can keep creating new technology that each new type of technology costs 10% or 50% or 100% more than the technology it replaces, because we can't afford it.
If we do not figure out a way to use appropriate evidence-based care, both in the diagnosis and treatment of this tsunami of aging individuals, we are going to eat up all the resources that could be used to diagnose and treat a lot of other people who either don't have access to care now or have inadequate resources to get the care they need.
It will take training of professionals, and it will take big changes at a policy level, including how care is reimbursed. But everything that we advocate for is ultimately extremely possible. I hope to look back 30 years from now, from my rocking chair and say, I was there. I was there when we built the system of care that truly respects the person with cancer and their family.
That specialist would be probably shocked that I haven't been hospitalized, that I've climbed the Great Wall. I've traveled, I've enjoyed, I feel good. And I would have had 2.5 bad years if I had gone the other route. As the cancer advances, and I really feel bad, I wonder whether or not the right person is going to be at my side, who's going to care about controlling my pain. I wonder at the very end whether I'm going to be able to stay home, because that's what I'd like. I do wonder what the end is going to be like.
I'm ecstatic that I've survived several years of cancer. I've got a wonderful family and great friends. As far as looking at the future with me, I'm dreading cancer returning. I'm over the age of 65 and things have changed. I'm afraid today. I'm afraid of getting cancer again.
4 years later, they tell me I'm in pretty good shape. I love the fact that I have a reasonable portion of health and strength, that I have family. When you find a wife, it is said that you find a good thing, and she is a good thing. Through my ordeal, she's been right there by my side, and she makes me happy. I'm back to my life again, and that's a good thing.
I've done well for 10 years with advanced breast cancer, which way surpassed any statistics. I have cancer in my lungs that is being treated, and my recent scans show that it has grown and spread. And I just started a new treatment 3 weeks ago, and I have high hopes that this will eradicate the cancer in my lungs. I'm currently on disability, and my disability is tied to my health insurance coverage. My ideal is to go out there and try my hand at a new career and try to establish myself, be independent. It's what I hope I can do, but the cost of medical care constrains me. I feel like the cancer care system is broken, and I wish there was a more patient-centered approach where you had the guidance and referrals to anything you need to proceed through this journey in the most successful way possible.
So now my charge is going to be to tell you what we did with all this information and the crisis that was just described in that video. As you can see here, our committee, our Institute of Medicine committee, was charged with looking at the opportunities and challenges to the delivery of high-quality cancer care and to formulate recommendations for improvement. And some of the specific issues we were asked to deliberate upon were the coordination and organization of care for cancer, outcomes and reporting of quality metrics. How would you know if you're getting good quality care? The growing need for survivorship care, palliative care, and family caregiving, the complexity and cost of care, and payment reform and new models for the delivery of care, and also substantial disparities and access to high-quality care in this country. But overlaying all of this was the aging of the population. And as you already heard in the video, there are 10,000 individuals turning 65 each year, and I will talk about what that means in terms of the numbers of cancer patients. So we had a number of study sponsors. None of these get done without financial support, and you can see the broad support from many funders that we had. And we had a wonderful and diverse committee made up of many different disciplines from many institutions across the country, and an outstanding Institute of Medicine staff that helped us with this. So in 1999, about 15 years ago now, the Institute of Medicine had an earlier report that was designed to first look at the quality of care, of cancer care in the United States. And they concluded that for many Americans with cancer, there is a wide gulf between what could be construed as ideal and the reality of their experience with cancer care. And this really shook people up. All across the country, oncology, professional societies, the federal government said, gee, we're really doing that bad, you know? And so there were many recommendations, very diverse recommendations, everything from end-of-life care to screening for cancer and so forth. And so there was an intense level of interest, probably for about 4 to 6 years after that period of time. But as with many sets of recommendations, they don't always have legs and they don't go forward. And so while it did raise a lot of questions and did some research at the time, we still had many challenges after this period of time. Their recommendations were that we should have evidence-based guidelines. Nothing new with that today. Quality measures and electronic data collection systems. Well, we're just getting electronic records, as you know, around the country now about 15 years later. That we should have coordinated high-quality care, especially at the end of life. That clinical trials should be much more prominently available to patients, and that there should be health services research to tell us how well we were doing in terms of cancer care. And there should be improved access and reduced disparities in care. And again, if you've read the newspaper, our disparities have actually increased over time. So again, over the past 14 years, there's been a lot of progress, but there's still many gaps. And I am actually part of an Institute of Medicine forum. It's called the National Cancer Policy Forum. And we have held many workshops over the last 7-8 years dealing with aspects of this problem in terms of delivering quality care, the shortage of the workforce, a healthcare learning system. And to go along with our consensus study, we actually in October of 2012 had a very powerful workshop on affordable cancer care. And a lot of the information that you saw in the video and that is in our report really came about because of our profound concerns about the rising cost of cancer care in particular. So this is what our report looks like. It was released on September 10th, 2013. And again, the overarching conclusion of the report was that cancer care is often not as patient-centered, accessible, coordinated, or evidence-based as it could be. And the report concluded that the cancer care system was in crisis, as you saw in the video, and we made very specific recommendations for delivering high-quality care, and I'm going to share some of those with you today. So these are some of those trends. You heard about them in the video. We're going to have an increase in the number of cancer survivors. So of the 1.6 million people diagnosed each year, probably over 1 million of them are going to be cancer survivors, again, adding to the number of people in the cancer care system. There are workforce shortages predicted, not just for doctors, but for nurses, for cytotechnologists, for radiology technicians. Everywhere along the healthcare workforce, there are going to be shortages. And certainly for cancer, we have a lot of specialized needs. There's increased reliance on family caregivers or direct care workers to provide the care at home for individuals. And again, the rising cost of care, which you heard about in the video. And again, you just need to read either the New York Times, Wall Street Journal, or LA Times, and you know what's going on. And the complexity of cancer care, the number of individuals that need to be involved in that care, and the preciseness and the diagnostic acumen that's necessary. And then really limitations in the tools to improve quality of care. We do not have very good scientific measures to say if you're going to institution A or institution B, you know, what is the quality of care you're going to get. So again, the majority of cancer diagnoses occur in older adults. This again tells us that more than half of them are in individuals over 65 years of age. Again, the growing numbers in that group. And the majority of cancer deaths are occurring in individuals who are over 65 years old. And this is the number of survivors. If you look, there are about 14 million cancer survivors today, and by 2022, we expect about 18 million. And you can see the aquamarine bar shows us the large number of individuals who are living many years after a cancer diagnosis, which is, again, very, very good, but they may be experiencing late effects or complications from the cancer treatment. So in order to frame this report, we developed a conceptual framework that really was the guidepost for the recommendations that I'm going to tell you about. And at the center of this framework are engaged, empowered, well-informed patients who are, in fact, collaborating with an adequately staffed, trained, and coordinated workforce, be that their doctor, the nurse, the social worker, many technicians, people who will work with them, who will understand and communicate and give them the care that they need. Not too much, not too little, but just the right amount. That we practice evidence-based care. And again, in cancer, we have more evidence than in many other fields because we do those large randomized trials. And that we should have a learning healthcare system, which I'm going to talk to you about a bit, which means that can we learn from people who are already being treated, perhaps with rare diseases or common diseases, or even for people over 65, since they're not in clinical trials, but they're going to hospitals and health systems, can we learn how they're faring with some of those drugs or treatments that we don't know about in enough detail? And then how can we translate evidence about what is the best care into delivery, and how can we measure whether health systems and doctors are doing a good job delivering the best care? And finally, how can we make this accessible, affordable, and delivered to everyone who needs that care? So this is a figure that we designed to kind of be a visual for this. And again, just to highlight, at the center is the patient. And I think that's what's really unique about this report. And wherever a patient with cancer is being cared for, they can have a conversation with their doctor about what's best for them. We don't have to have all the bells and whistles, but this can be the minimum. So again, just to kind of explain to you about cancer care, it can start with screening, which is off to the left, and prevention and doing risk reduction for people. But our report actually started with what happens to people at the time of diagnosis and how they get through the diagnosis and treatment and what happens to them afterwards. And things that we recommended, and the report goes into great detail about, are things that need to start at the time of diagnosis, which includes care planning, palliative care, again, managing any symptoms or concerns that the patient has, psychosocial support, again, helping the individual cope with that diagnosis and get through their treatments, and prevention and management of the long-term and late effects of treatment. If we expect someone's going to be a survivor, we should do fertility preservation rather than have the young woman or young man become infertile, and that has to be done up front. And then family and caregiver support. So here are the overall goals of the recommendations, and I'm going to go through them. It's, again, a long list, and you can look at the book in detail if you want to. But again, this is the list, and I'm going to go through each one of them as well as the recommendations that went with them. So again, at the center and heart of our framework and our model are engaged patients. And that means that the cancer care team should provide patients and their families with understandable information on the cancer prognosis, the treatment benefits and harms, so what are the choices that you have, palliative care to manage any symptoms that you may be having, psychosocial support, and estimates of the total and out-of-pocket costs associated with that treatment, because there can be huge variations with different treatment choices, and patients may have preferences about this. Patients want to be involved, and again, this is from a survey that was not done with cancer patients, but other kinds of patients. Patients want involvement in their decision-making. They want their physicians to listen to them, to tell them the truth about their diagnosis, even though it may be uncomfortable or unpleasant, to tell them about the risks associated with each option, and to explain how options may impact their quality of life, what you saw Mr. Roberson talking about in the film. We want patient-centered communication, and that means having a patient who's informed, activated, and participating in their care, and again, be oriented to an accessible and well-organized healthcare system. And with this improved communication, we expect to have better and improved health outcomes. And again, this diagram shows that palliative care, which many people in this country think is end-of-life care, but palliative care is necessary along the whole continuum. I have a survivorship clinic, and what I do with cancer survivors is provide palliative care. Their cancer is gone, but they have fatigue, pain, or depression, and I have to treat those symptoms. We have to do that from the time of diagnosis going forward. So recommendation 1 was that the federal government and others should improve the development and dissemination of this critical information using decision aids when possible, that professional educational programs should train clinicians in how to do a better job in communication, that the cancer care team should communicate and personalize this information to their patients, and that they should collaborate with their patients to develop a care plan at the beginning of treatment. And CMS, which is the federal government that funds Medicare and Medicaid, and others should design and implement and evaluate innovative payment models to, again, reinforce and pay for this kind of communication. The information in a cancer plan, I'm not going to read all of this, but it should be enough so that the patient really knows what is the road going forward. And this is just, again, to show you that whole issue of bankruptcy. This was a study done in Washington State where they merged cancer registry data with bankruptcy claim data, and they found that cancer patients had more than 3 times the rate of bankruptcy than others in the population. So again, not knowing the costs of care is a big problem. Goal 2 in this setting of advanced cancer care teams should explain to patients and provide them with information about end-of-life care that's consistent with their needs, values, and preferences. And again, the recommendations that go along with this goal, again, similarly to communication in general, we need to have clinicians who know how to communicate at the end of life, that the team can, along the time that a patient may have advanced cancer, can revisit the patient's desires and wishes in terms of their care, and that certainly in this group of patients, we have to systematically offer to them palliative care, psychosocial support, and timely referral to hospice and end-of-life care. Again, it's a shame in this country that many patients get to hospice less than 7 days before their death, and they have advanced cancer. So again, we need new incentives to do this and have asked the payers to develop innovative models to do this. We need an adequately staffed, trained, and coordinated workforce, and again, that means we need to promote that kind of communication. And certainly, within the cancer care team, there isn't always very good communication going on, but patients have primary care providers or geriatricians or other specialists, and they're completely out of the loop in most settings when patients have cancer. So we need to do a better job with that, and everyone has to work together, again, with the patient at the center. And again, coordinating across specialties is also very important. So recommendation 3 was that federal, state, and state legislative bodies should eliminate reimbursement and scope of practice barriers to team-based care. Right now, many nurse practitioners, nurses, physician's assistants will not be able to work at the level they've been trained because of the rules that are operating in some states. Academic institutions and professional societies should develop interprofessional educational programs, and there is a national workforce commission that was part of the Affordable Care Act, and again, this has been recommended but not funded by Congress. We need an adequately staffed and trained and coordinated workforce, and this means that other people who are not directly delivering cancer care need to have some core competencies in this. And here we ask professional organizations like the Oncology Society and so forth to define what does a general surgeon or a nurse on a regular floor need to know about, or someone from the Visiting Nurse Association to know about cancer so they know who they're taking care of. And again, we need to accredit them in terms of training programs. We need to have evidence-based care, and this means that we can continue to do clinical trials in the way we've been doing them, But as you heard in the video, many older individuals don't participate in clinical trials, and they're the ones who are going to be getting many of these drugs, so we don't know about the toxicities. So we asked that the federal government and other funders of research include a plan to study a population that mirrors the age distribution and health risk profile of patients with the disease, and we asked for a patent extension to be made by Congress for studies that could be done in older adults after the primary approval might be done. Something similar was done for pediatric patients because many of the life-saving drugs that we have in cancer were not being tested in pediatrics because the drug companies didn't see any advantage to doing that. Evidence-based care, we need to collect more information about who is getting cancer treatment and what kinds of problems they're having with treatment. And again, we call on the funders of research to develop common data sets and elements and really emphasize the patient experience. If people are being treated for a disease, subsequent patients will want to know what was that experience like, and we can only learn about it from the voice and experience of patients who have gone through that treatment. We want the learning healthcare system that I talked to you about. Millions of people are being treated for cancer every year in this country, but we know little about their outcomes. Well, we have this chance to harness the big data, if you will, that's going through the healthcare system and learn about how people are responding. And we may make new discoveries about great benefits that we didn't know about, and certainly we could learn about harms. And this particular visual just tells you about how we might be able to use data routinely used in care that could be analyzed and generate new information for future patients. So we want professional organizations to design and implement the digital infrastructure and analytics to do this. The American Society of Clinical Oncology, which I belong to, has already developed a prototype for this. So again, we know some of these things are in the works. We want the Department of Health and Human Services to support this kind of research opportunity and to have payers participate in this because often this will need to be linked to insurance claims. We need to have better quality measurement systems, and we need a national quality reporting system, again, so we know about what is good quality care for cancer. And again, we've asked for Health and Human Services to work with professional societies to create and implement a formal long-term strategy for public reporting of quality so that, again, you as a consumer will know what you're getting for the care that you expect. To prioritize and fund the direct development of meaningful measures, and also to implement a coordinated and transparent reporting infrastructure again, so these things will be available to people when they have a new diagnosis. We want this care to be accessible and affordable, and again, this is a real challenge, as you've heard about the exploding costs, and we want to reduce disparities and improve access to care. And again, here, the ask is for Health and Human Services to develop a national strategy that leverages existing efforts around the country. There are many experiments going on in local communities to make sure that people can get to treatment in a prompt way and get the services that we need. We don't want a top-down effort. We want to support what's going on in communities and, in fact, replicate those innovative strategies if possible. And again, we have to improve the affordability of cancer care. And again, there are many activities going on across the country in various states, but also at the federal level. And we're going to be seeing changes in reform and payment in the future. We didn't recommend a specific strategy, but we know that these are going to be coming forth. And we want professional societies, because I think the physician is often in the best position to decide what's best for their patient. And what we made a strong recommendation for is that when therapies are not useful and when they may harm patients, we don't want to recommend them, okay? And we can do that as physicians. We are already doing that. We need to educate the public, though, about this so that it doesn't appear that it's rationing, because that's not what we're about. We're really asking that we don't give treatments to people that may be harmful and may be very costly to them as well. We want CMS and others to develop payment policies that reflect these findings, and that CMS and others should design and evaluate these new payment models. And if one is found to be favorable or superior, that this be implemented. So there's something called the Choosing Wisely campaign. I don't know if any of you have heard about this, but there are about maybe 100 medical societies that have participated in this. I've actually just shown you some of the oncology societies, where each one has come forward with 5, or in the case of ASCO, we've come through 10 things that really are unnecessary and not beneficial to patients, and have suggested that they not be recommended, and we encourage discussion with patients about why they're not recommended. So in conclusion, this report really says that we have a challenge ahead of us, that the cancer care system is in crisis, really because of the aging of the population and the large number of individuals who are going to be needed to be treated for cancer. Again, it's not an epidemic, it's just because there are more people in the population at risk for the disease. There are unsustainable costs. The care fragmentation makes it very difficult. The patient is the one who has to be communicating with everyone. We want the doctors and everyone else to communicate with the patient and with each other. And this report really charts a course forward with many activities, I have to say, that are in process. Again, it looks overwhelming, but we know that a lot of people are taking up the challenge. And again, there's a heavy emphasis on affordability and reliance on the professional societies, but I have to say many of them have also taken up the mantle to try and improve things, because we know we're not going to be able to practice medicine the way we would like to unless we meet these challenges. And we need payment reform and new models of care to be able to do this. So this is my last slide. This is the report. You can find it on the National Academy Press website. If you'd like to look at the video again, that's up there as well. And the cover of the book was actually something that was painted by a cancer patient. So thank you very much for your attention.